Hey, good morning, everyone, and welcome to Urinurse. We meet every Saturday, 9 a.m. Nice sunny day today. Glad to have everybody on board. If you're watching this on YouTube, LinkedIn, or Facebook Live, welcome to the show. And hey, you YouTube subscriber doing a great job. We're at 668 subscribers. Remember, I want to hit that 1,000 mark, so help me out. Again, if you're watching us for the first time, be sure to check out our website at urinurse.com, where you can learn more about the show. Best place to go to learn all the information you need to know about the show. And it's also the best place to go to watch all of our past episodes. There's 67 of those out there now. And hey, if you want to listen to us in your car, go check out our audio podcast using our Urinurse Plus box. And it'll take you to all your favorite formats to watch us, or listen to us, I should say, in your car anytime you want. We are helping Suna out on this workplace compensation survey. You can go ahead and click on this little survey thing over here, or you can go to our website and just click it. It'll bring you over there, or scan the QR code. But help them out. Get that. If you haven't filled it out, fill it out for them. And we do have our newsletter. Be sure to check it out. It comes out every Monday with all our information about upcoming shows. And if you're watching live, hey, fill out that comment box. We're glad to answer your questions. This week, I'm going to be talking on the second half of microscopy, or second half of urinalysis, going into the microscope. So for those of you that are familiar with it, maybe this will be some tips and tricks. For those of you who've never used a microscope, maybe this will be your way to get involved using it. At this point, I would like to bring in our experts. Let's go ahead and bring those in right now. Hey, welcome, John. How are you doing?
Good morning, everyone.
So you can see two pictures of me today because I'm going to be going over to a second camera to do this. I can use my telestrator that way. So that's why I'm over in this goofy spot. But that's a small technicality to the trying to get everything to work today to give you guys the best show. So I'm going to be the presenter today for today's show. I've been around for the last 40 years in urology. This is my way of passing this forward. My favorite stories are all going to come during the show. So I'm going to bring John in to do his introduction. Go ahead, John.
Good morning. My name is John Lynn. I'm a urologist in Gilbert, Arizona, which is just a little suburb down in the Phoenix area, Phoenix, Arizona. I now am in a very fortunate position where I get to share my clinical and business aspects of knowledge with other urologists and other urology practices all across the U.S. And in helping me do so, I created the Thriving Urology Practice Facebook group, where we crowdsource practice management solutions for everyone's benefit. There's always so many stories that I can share. And the story that I'll share today involves what we're doing now. And I'm going to encourage you to consider joining us in this panel. A lot of times we are afraid to be on camera or to share our ideas because we're always worried about what other people may think. Are they going to think that we're dumb, we don't look right, we don't sound right? But I'll quote you something from Eleanor Roosevelt. And she said many years ago that you wouldn't care so much about what other people think of you if you realize how little or how seldom they do. So keep in mind that we are always worried about what we're going through. We don't really care so much about how you look, how you sound. We just want you to share the information that you have. And Vic, with his vast experience in urology, I find his perspectives often very, very instructive, if you will, having that background and what has transpired in the past. And then he's not just resting on his laurels, he's constantly learning new things. He talks about AI, he talks about new technology. Heck, he's doing this live stream, and he's been in urology for 30 years, and he's got more gray hair than I do. So I encourage you to join us on this panel, and you just reach out to Vic via urinurse.com. Back to you.
Yeah, thanks. Great. Always a great story that you have for us, John. So really appreciate it. All right, so I'm going to go ahead and try to switch everything over. So fingers crossed, we'll see how this works.
You got this.
I got it. I'm almost confident. Hey, it's actually working. So let me switch mics, folks. I'm just going to get over to this other mic here. And so we are going to go into our second episode inside the world of urinalysis. It's our more advanced. I don't think that everybody does the UA with the microscopy. I'll have a question for John later because I know he's our expert in billing because it is billed differently. So it may be even worth the cost of having a microscope. But I think it's worth learning because there's a lot of things that you don't get from our normal talk that I spoke about with the automated UA machine. And if you remember last week when we talked about the urinalysis, we said, it's your eyes, nose are your number one things that you use to evaluate urine. And then of course, these test strips in the machine are the secondary things that we use. And those really give us a lot of great information. And we know that we can tell if there's detect leukocytes, nitrites, urobilinogen, proteins, pH, blood, specific gravity, ketones, bilirubin, and glucose, all with that test. All very helpful things for screening. But they're not the end of the spectrum of what you can find out with urinalysis. And that's why I say, why do we need microscopy? Well, what it provides is detailed information about the cellular and non-cellular components of urine. Now, you need to have some equipment in your office. A microscope, obviously. Here's a centrifuge, and you don't have to have a centrifuge, although I would recommend it because I think it's hard to look at urines without having the magnification that you get with the centrifuge by concentrating things. Definitely slides to mount them on. I see people not using cover slips. You're going to say wear and tear on your microscope, and I think you get a better view if you use one. So we'll go through all those steps right away. But let's start off with the centrifuge. What is it? So we all, I think, remember from our science classes, centrifugal force. If you spin, things are going to go and get heavy and drop to the bottom. And that's what happens. It concentrates the cells, which is what we want to look at, towards the bottom. So let's go ahead and bring up our little centrifuge information. So how to use a centrifuge. It's important, as you can kind of see right here, we're loading up the specimen. That's that green stuff. They're using a color so you can see. But you always have to have what we call a loading cylinder also to balance it out. So when you're spinning a sample around, if you've only got the one container in there, it's going to be off balance. That off balance can often lead to a spinning nightmare. It can cause a lot of shaking and vibrations, and you can actually have it walk off your countertop. So you can see how we're loading this up. One goes right across from the other one. Now, if you loaded them all, that's fine, as long as you have a balance. And they should be about the same amount of fluid in them. And then we always use these closed type systems so that there isn't any risk of test tube shattering. It showed 5 minutes. I don't really spin urines for 5 minutes. A couple minutes is typically enough to concentrate a urine sample. But anyway, that's how we use the centrifuge. Pretty simple. Now, the one thing I think a lot of folks are worried about is after you centrifuge, how do you get that fluid separated? Just dump it like I showed there. People are afraid they're going to lose this little bit that's in the tube, but it stays there. That's the concentrate. It'll always stay on the bottom of the tube. You don't have to try to do it tenderly to make it not fall out. So as you can see there, I'm putting the slide sample on the slide. And now putting my cover slip on. And now I'm ready to put it on the microscope. That simple. By the way, that's not urine. That was my morning coffee. I just thought it would show up better. So again, here we see in this slide here how you kind of place the cover slip carefully on there. This slide was not me. That's not my hand. I had gloves on. The other important thing is, what power microscope do you need? Do you need to have all these lenses that you see here? And I'm going to tell you that right now that you need two. You need a low power lens and a high power lens. So the 4 and the 40 are the ones that I prefer to use. And I'll show you some of the differences as we go through the study. How fancy of a microscope do you need? Well, there's some basic things that you have to have. Do you need 2 oculars on it? No, you can do it with a single one. If you're going to look at a lot of urines, and typically in a day, I would say I was looking at 30 urines a day. That's a lot of eye strain if you have to go through one and you're kind of like closing one eye or not, focusing with the one eye. So I like the binoculars system. So I don't think it's all that much more expensive. You've got this area with your lenses mounted here, and then you've got your stage, which holds your slide. Most good systems are going to have a slide holder and a control to move that so that you can not have to touch it to move it. This is very important. There's 2 adjustments that make this stage go up and down. A coarse one that moves it a lot, and then a fine adjustment, which just moves it a little bit. And you need a light source. Now, you need a light source, you need a way to control the light source, and you need a way to contain the apertures, just like a camera lens. You can make it wider or smaller to focus that light even better. And we're going to go through this little video right now. I'm going to bring this up to full screen for you here, because this really goes through all the parts of a scope. So you can see we can turn our light level up and down. And that's that aperture I was telling you about, how it can open and close. You can kind of see the light up there is changing. The biggest mistake I see people make is that they will have the light open too much. And I'm going to show some slides that show what happens when you do that, but the light will blow right through the cells. You'll think you're looking at nothing, and it's just because you've got too much light. So I always close it down until you really can see things good. And then we can kind of see the stage up there, and that's very similar to the ones I have. These eyepieces have adjustments. If you've got different vision in each eye, you can kind of correct for that. They are adjustable for your pupil distance. So if you're wider or narrower, you can adjust those so that you can look. Once you get this set up, it's pretty easy just to kind of keep it there. Again, my prejudice is the double. I love it. And then there's our different size powers. So this is our low power, which is 4. And they kind of mentioned in the slide that the way you figure out how much you're magnifying everything is by multiplying the oculars, which are at 10 power, times whatever lens is there. That's a 4 power. So 40, that would be 100. I don't use the 10. I actually don't even have it. You can pay for these separately, so I wouldn't even bother with a 10. So that would be 100, as it says here. And then this one that I do use the bulk of is the 40, which is 400 power. I know some people that'll just look at it under low power, depending on what you're trying to do. It's important when you're reporting these things out to mention whether it was high power or not. This last lens, 100 power, is what's called an oil magnification lens. You have to use a special oil to utilize it. I have one. I never use it. So here's that adjustment I was talking about. The coarse one, you see how much the table is moving? And then if you go to the other ring, it moves it in tiny increments. And in order to kind of look at cells, because they will vary, you do have to kind of move this up and down, those little notches, to kind of see up and down, because we're looking at our sample as if it was like a loaf of bread, one slice at a time. So you got to go up and down that loaf of bread to see different things. And then I always like to get a table that you can move with these knobs. So one adjusts it forward and backwards, the other one side to side, because you're going to look at more than one spot on the slide. So it gets you where you want to be. And again, these click into place so you can pick your power. So once you are getting ready, I always start with the lowest power because it's easier to focus on than trying to start with a high power. And once if you're focused on the low power, your high power will also be in focus. So it's a pretty easy way to get that set up. We can see that we're getting that set. And so now the first adjustment is done with the coarse. I've got a little locking tab on mine, which is really nice. Once you kind of find where your basic spot is, you can lock it in place. So it makes it a lot easier. You don't have to keep monkeying with it. But that's the basics to how to use a microscope. Now I'm going to go ahead and give you my tip of the day. So this is our slide and this is our cover slip. When you're trying to focus, what I recommend doing is to get your focus right here on this line of the cover slip. It's real easy to see that line when you're trying to find where you're at. Trying to look right here, and I'll tell you, first of all, a sample that's loaded with bacteria or loaded with cells, real easy to focus on. A negative urinalysis, hardest thing to focus on. So when you don't have much in there, it's hard to find. So finding this line is a good way to get yourself kind of started where you're at. Once you can focus on that, then you can use that fine adjustment to kind of get in the right area and then move your slide back and forth this way to get over to this area to do your exam. So pro tip, what do we see when we're looking under the scope? All sorts of things, blood cells, white, red, squamous cells, skin, which are skin cells, cast, bacteria, yeast, sperm, and then crystals. We've got kidney stones are crystals, so we get to see if some of those are forming. So let's start with the white blood cells. And then the first thing that you look at when you're trying to figure out if it's a white blood cell or red blood cell is the cytoplasm, what's filling the cell. And this, by the way, is 400 power, just so you know. So we can see that a white cell has this very granular looking texture to the cytoplasm, and it has a nucleus, so it's not as easy to see depending on where you're at. But that's the two clues that you're looking at a white cell. They're bigger than red blood cells too. Bacteria have two different formations. So these are rods. So we can kind of see those. This is typically what you see when you have an E. coli. And then cocci, which are these little round dots. Those are bacteria also. So they can be round or they can be rod shaped. And you'll see those under your scope. Now here we actually have a live action view. So you can see, here's the white cells right there. Pretty easy to see. And we're going up and down and focusing. And these are the bacteria. And yeah, that guy's doing the Macarena. So it's, this is live. You can actually see the cells, the bacteria swimming around. So this is definitely a UTI. High field. I'm going to show you how we're going up and down. Now, this is if you have too much light. See how you can barely see the bacteria there? If you've got the light open too far, you can blow right through the cells. And this is a pretty contaminated system. Now, as we go in closer and closer, I'm sorry, not closer and closer. We close down that light. Now, all of a sudden, the bacteria really pop, don't they? And that's the whole key. So you got to be careful you're not putting in too much light. Not enough light isn't going to work, but you'll do better if you start dark and then open it up rather than starting bright and trying to close it down. So what's sperm look like under the scope? So this is low magnification. And if you're looking here, you can just see all these little guys swimming all over the place. We're going to go up to higher magnification here in a moment. And that's our 400 magnification. And it's pretty easy to see that these are sperm swimming around. Now, if you're doing sperm counts, you have to have a special grid that allows you to count sperm. And if you're doing post-vasectomy samples, that would be not a very good one to see after a vasectomy because you see a lot of live sperm, you see some dead sperm. I've encountered a few of those in my days. Trichomonas is a sexually transmitted disease, sexually transmitted infection caused by a small parasite. And you can, once you've seen them, you can't unsee them. If they're there, you'll find them because they're pretty descriptive once you get a look at it. Just so you know the symptoms: vaginal fluid smells bad, greenish or yellowish, complaint of itching, pain with urination, frequent urination, all kind of the normal things that we see with urinary tract infection. But here's what this little guy looks like. And we can kind of see him dancing around here. And the real key, and I've got some better pictures coming up here, is this kind of pear-shaped body with this one single flagella that they use to propel themselves around. Now here's a better one. They're going to point it out. You can kind of see that little flagella thing it's swimming around with. By the way, these big cells here, that's a vaginal squamous epithelial cell, which means that this most likely was a vaginal smear that they're looking at, vaginal fluid. So there we can see that little guy swimming around. Like I said, once with combining those symptoms and seeing that little guy floating around there, pushing himself around, almost the size of a white blood cell, but blood cells don't have flagella. Yeast cells are the other things that we see. Yeast is can be a contaminant from a badly caught sample where there was a yeast infection from a vaginal infection, or sometimes yeast that guys that are not circumcised may sometimes develop, or more likely overtreated urinary tract infections, right? So here's what the yeast looks like. It's kind of a small cell. It's clear, and we usually see them in groups. They call it budding yeast. And we're going to see that popping up here on this picture. And there you do see a few bacteria, some rods in there too. Most samples are not going to be one simple thing. It's going to have multiple things. This is really a good example right here. That's that budding yeast. Kind of see them sticking together. Again, I think once you start looking at these things on a regular basis, they're really easy to spot. These are really easy to kind of see. These are where we see almost look like grapes. I have a vineyard in my backyard, so I always think of how things look like compared to what I got at home. Those are exactly what yeast look like when they're congregating together. RBCs, I think, are sometimes the easiest thing to find. And we mentioned why that's important, because when we talked about that urinary dipstick question last week, and we said, is it significant if they've got positive tests for hemoglobin with the dipstick, it's showing trace blood or something, but they don't have any blood cells in their urine? Well, this is how you find out. You have to look under the scope. And you will see red blood cells. I'd say they look like a donut that didn't get poked all the way through. The other thing is they're almost clear. They don't have a nucleus. And you're going to see the best way to be able to see them, and here's our RBC right there, a couple of them, is by focusing up and down. As you see, as we're changing that focal, you can kind of see that donut shape showing up there. And these other things, as they're showing out, these are the pus cells, are white blood cells. Now, as I mentioned, you would report this as, 1, 2, 3 RBCs per high field. So we kind of went through that little algorithm that the AUA put together about what choices you make based on how many blood cells you see in the urine. So this would be a very low number of cells that we're seeing, but I thought it's a good sample to look at because it shows you how you can pick these out pretty easily. And again, as I said, they're not by themselves, because we've got there's a blood cell, there's a blood cell over there, red blood cell, and then there's our white blood cells. So they kind of stand out from each other. But you got to go up and down with that fine adjustment to see these formations where you kind of see that disc, biconcave disc. I mentioned a little bit earlier, we talked about squamous epithelial cells. They're the largest cell you'll see typically on a sample, and typically found from the vagina and in the urethra. And I think once you see these, you can't miss them ever again. They have a very prominent nucleus. And they're just big old honking cells compared to everything else. I mean, compared to a white blood cell, these things probably on an order of about 50 times bigger. Sometimes if you're doing a urine sample and you see a lot of these in the urine, a female catch sample, you may wonder whether there was a contamination in how they caught the sample, because that was getting washed down from the vagina. But again, you can see, and I kind of show you how this slide is moving around. It's that little adjustment thing on the stage that you do that. So you want to kind of get an idea of what's on the whole slide, looking over the whole slide. The other thing we look at besides cells are crystals. We know that kidney stones are an issue. And if we start looking at these names, uric acid, cysteine, calcium oxalate, these are all the things that we find kidney stones made of. So let's take a quick look here at our uric acid stones. They're nice and easy to find because they call it box or diamond shaped. And here's a sample. So we kind of see that thing right up there. That's a uric acid. Sometimes they can have that more like typical diamond versus that little box. Again, you have to focus up and down. Crystals are a little bit larger, so they're sitting in multiple planes. This is an example, again, how you're going up and down to see those crystals better. I like to see crystals because they kind of look neat on the scope. They tend to reflect the light, so you get that really neat looking object. Calcium oxalate, once you've seen one on us, you'll never miss them, because they look like if you had an envelope and you were mailing it, you know how they have those creases in the envelopes. So that's the best description for a calcium oxalate stone. And they always reflect the light like crazy. So you get these beautiful like star things. As beautiful as urine can be, right? We can kind of see, again, I'm going up and down to try to get some of these in and out of focus to focus different areas. But again, once you see them, it's hard to unsee them. You're always going to be able to pick those up pretty easily. The other thing we're going to talk about here is urinary cast. So what are they? Well, they're proteins, blood cells, bacteria, epithelial cells, fatty cells. They're pretty can be fairly common. There's some typical causes of those, and there's some very serious diseases associated with them. And I've got something I didn't put together, but I'm just going to play it because I think it really covers what you need to know about cast. Most importantly, they're caused by an increase in the TAM horseball protein. They're called cast because it's like they're doing a plaster cast of the inside of the tubule. They're found and created up in the distal convoluted tubule of the kidney. So let's go ahead and take a look at that.
Hyaline casts.
Hyaline casts are the most common type of casts, which are composed of solidified TAM horseball mucoprotein. They have smooth texture, and a refractive index very close to that of the surrounding fluid. Generally, hyaline casts have parallel sides with clear margins and blunted ends. Hyaline casts can be seen even in healthy patients, but they may be seen in increased numbers during dehydration, during fever, exercise, or diuretic medicines.
Granular casts.
Granular casts result either from the degeneration of cellular casts, or direct aggregation of plasma proteins, or immunoglobulin light chains. They have a textured appearance, which ranges from fine to coarse in character. Their appearance is generally more cigar-shaped and of a higher refractive index than hyaline casts. They are seen after strenuous exercise, chronic renal diseases, acute tubular necrosis, etc.
Waxy casts.
Waxy casts appear as cylinders of smooth. They are more refractal, and therefore easier to see compared to hyaline casts. Waxy casts represent the final stage of degeneration of cellular casts. They are usually seen in severe chronic renal disease, renal amyloidosis, and acute and chronic renal allograft rejection. Unusually broad waxy casts are known as renal failure casts.
Fatty casts.
Fatty casts are formed by the breakdown of lipid-rich epithelial cells. These contain lipid droplets within the protein matrix of the cast and are identified by the presence of refractal lipid droplets. They are usually seen in the conditions like tubular degeneration, nephrotic syndrome, hypothyroidism, frequently associated with heavy proteinuria.
Red blood cell casts.
Red blood cells may stick together and form red blood cell casts. Such casts are indicative of glomerulonephritis, with leakage of RBCs from glomeruli, or severe tubular damage. RBC casts have been described along with hematuria in healthy individuals after exercise.
White blood cell casts.
White blood cells are present within, or upon casts. These casts are typical for acute pyelonephritis, but they may also be present with glomerulonephritis, acute interstitial nephritis, lupus nephritis, and acute papillary necrosis.
Renal tubular epithelial cell casts.
These casts are composed of renal epithelial cells. Seen in conditions such as renal tubular necrosis, viral disease, and kidney transplant rejection.
Hemoglobin cast.
Appear yellow to red or even pale color. Usually seen with RBC casts and glomerular diseases. Rarely seen with tubular bleeding and hemoglobinuria.
So there we have it. As we can see, that it was a nice, I think a really good video I was able to find on the different casts and why they're so important, and why some aren't, but typically all have that cigar shape, which is because of where they're formed. And so they said Highland casts can be just simple dehydration over exercising. RBCs can be indicative of glomerulonephritis and white blood cells, infections, bacteria. So it's important to know if you see these casts that what ones you need to work up, which ones you don't. Now we're going to our test time. Everybody's been watching this. I've got a nice live audience I can see. And what I'm going to do is I'm going to run through 7 slides of the things that we've been looking at. And I want you to, you don't have to write these down, but just keep track. You can keep track with your fingers or whatever of which ones you get right. So it's going to show you, and then it's going to give you the answer. And then no shame if you don't want to write it down. But if you want to put in the comments how many of this out of 7 you got correct, I would really be curious to see how well I did. Because you see, I'm not grading you, I'm grading me. If you get 7 out of 7, I did a pretty good job. If you did less, then I didn't do so well. So after we finish the test, I would like it if you would go ahead and put your test scores down for me and let me know how I did. Okay. And here we go. I'm going to make this full screen for you, give you the benefit of all of the stuff you can see. So number 1, and I apologize, this is kind of a bad looking thing, but these are little balls. Yep, that's our bacteria, cockeye shaped. Number 2. And that's definitely what that little arrow's pointing to. Do you know what it is? Yep, that's an RBC. Remember, no nucleus and the donut shape. Number 3, what do we got here? Got those, yep, head and tails, sperm cells. Number 4. Remember what that is? Yep, the Trichomonas vaginalis, pear-shaped, got a flagella on it. Number 5. Yep, that granular WBCs, granular appearance. There is a nucleus. And number 6. Remember I told you once you saw them, you'd never forget them. So yep, that prominent nucleus, big cells, epithelial cells. Could be skin, could be vaginal. And our last one, number 7, those things we're pointing to. The answer is yeast cells. So go ahead and fill that out. How many of those did you guys get correct? It'll be kind of interesting to see how everybody did. If you go ahead and fill that out right now and into the question or the comment box, to see how I did. Remember, your score is my score. So go ahead and fill that out and we'll take a look at those scores here in a moment. While we're waiting for those to come in, I do want to make a recommendation. If you're going to be doing urinalysis in your office and you don't have a book on it, I got a couple of books that I would recommend. This urine and body fluid one is a paperback. It's got a lot of nice pictures in it that Nancy Brunzel puts out, and pretty cheap, $5.79. But if you want to really get the best one, the Handbook of Routine Urinalysis by Laureen Graff. A little more expensive, $30, but well worth it, because I can tell you when I started out, that's how I would, if I got something I wasn't sure of, I would go through the book and kind of see if I could figure out by matching the picture. So it's good to have a backup to how, what you think it's going to be. And with that, I am done speaking. So I'm going to go ahead and switch it over to our Q&A and bring in our expert, John, on this too. All right, John, how'd we do?
Very well. There is a question in the comment section. I think someone is watching on YouTube on Urinurse.
Oh, yeah. That was one that was sent in from somebody from the audience before the show came out.
Very good.
So I'm going to see if I can get myself out of this other picture.
There we go.
Now, whoops, I got to mute the other one. Okay. Nope. Now Well, that won't work. So let's
Maybe continue using the other microphone. Now you're muted.
Yeah, I'm gonna have to add myself in.
Now you're good.
All righty. Well, so much for technology. Anyway, let's get to that question. It was sent in by Wadong Yaing from Carmel, Indiana, nice suburb of Indianapolis. What causes positive nitrate besides UTI? So, first of all, nitrate is something that we don't detect on our test. Nitrite is what we detect. And nitrates are produced by all sorts of things, foods, vegetables, and things like that. So they're almost a normal thing to find. But again, we don't test for them. Now, the question is nitrite. What would cause that? And the only thing that causes that is a bacterial infection, because bacteria are what convert nitrate to nitrites. So it's a really good test for checking for an infection on a sample for UTI. And our second question, does
Before you
WBC...
go on,
Yeah, go ahead.
so what else can cause false positives on the nitrite on the urinalysis dipstick is that, remember when Vic was describing how the urinalysis dipstick should be done, is that it should be a timed test. So if you leave that strip exposed to air for too long, it can produce a false positive on the nitrite section. In addition, if you have a patient who's been taking pyridium, phenazopyridine, clearly you can see the urine looking orangish, right? But then if you should dip that, often you will see nitrite turning positive on the urinalysis dipstick. So those are the two situations where you make it a false positive on the nitrite on the dipstick.
Oh, and I just want to get that second question is, does WBC in the urine always indicate infection? And absolutely not. And I think we spoke to it before about a perfect example. Somebody's on BCG therapy. So they're going to have more white cells. White cells just indicates the body's trying to fight something. Could be infection, could be inflammation from a stone, could be post-surgical. There was an operation and they're still producing white blood cells during the healing process. So that's a very unreliable way of diagnosing a UTI. I'm going to take a quick look here and see. I do see some grades coming in here. April 6th, not too bad. Curious which one you missed. Monica 7, great job. So I should say which one I missed, because I'm the one who didn't get it good enough for you to learn it. Olive got a 7. All right. Elizabeth 5, not too bad. But how would competency be checked? CLIA approved. As far as for doing the urinalysis, how would it? You'd have to be have someone who is certified to approve that. I don't really get into the CLIA approval part, so I don't know if I'm good one to speak on it, but that would be a good question to have answered. Let's see, Gene, 100%, great presentation. I love the illustration of the old guy looking through the scope. I become an artist now since Mid-Journey came out, so I'm really good at making some of these up. And Susie, 5.5 out of 7. 5.5. You were sort of right.
She's hedging on her answer.
Hedging on it. But really a lot of Janelle says azo being one of the things that could miscolor. Yeah, any of these antispasmodics that have dyes in them are going to throw off the urine test. There's no question about it. And Elizabeth Hernandez also said azo. Great. Be sure to put in your questions. Usually I have one of my associates working today to run through the questions, so I'm going to be looking over to glance at those. But any discussion you might have, John, to add to urinalysis?
Yeah.
First of all, I do have a question for you, though, before you go into it.
Yes.
Can you talk about the reimbursement as far as urinalysis for with or without microscopy?
Yeah, I hate to burst your bubble, Vic. So there are two codes. Typically, this is how they're built. So the first code is 81000, and I'll show this to you on the screen. I'm using auacodingtoday.com, and the print is going to be pretty small. So if you're watching on your phone, it's going to be difficult. I'll try to enlarge it. 81000 is urinalysis by dipstick or tablet reagent for bilirubin, blah, blah, blah. Non-automated with microscopy. And if you scroll down the bottom here, and I'll try to enlarge it. You see that right there?
Yeah, I got you up on full screen now.
Yeah, $4.02 for all the effort. First of all, having to spin down the urine, having to centrifuge it down, decant, and then take the specimen, mount it on the slide, put the cover slide over it, mount the slide on the stage, and using someone who's extremely trained and experienced to interpret that urinalysis, and then entering that result and reporting that. $4.02. And then if you were to look at 81003 UA, any number of these constituents reported automated without microscopy, meaning you just dip the urine and then blot it and then put it in a machine and it reads it out for you. $2.25. So you're talking low, very low reimbursement for doing these urinalyses. And I think what Medicare, these are Medicare rates. What Medicare is doing is that they're trying to, I think, encourage you almost not to do the microscopy and automate the urinalysis, which is unfortunate. So the bottom line is, from a financial perspective, from a business perspective, it is not worth your while to do it under microscopy.
Now, how about a cool factor?
Oh, absolutely cool factor. I mean, you can see the sperm, you can see the flagella, you can see the red blood cells. It takes a lot of I guess if you're used to doing it, it's not so difficult. But if you're just starting out, it takes finesse, it takes technical knowledge. You have to understand light refraction. You have to understand the binocular aspect of the microscope, the adjusting interpupillary distance, adjusting the eyepiece settings so that you can see clearly, and then the minute differences when you move the stage up and down so you can see the different micro layers of the specimen that you're looking at under the cover slip. So it takes a lot of skill to perform this very valuable test. But I think from a business perspective, it is encouraged by this low reimbursement for us to outsource that, to have the lab do it.
Yeah, no, you're absolutely right. That's always been the issue, is you really don't have the bang for the buck out of it. However, it's can be, it's nice to be able to do something in your office, instantly have a report for a patient. Somebody comes in, oh, I tested, they came in from their primary who did a dipstick and said, you're positive for blood. And then they come in and they want to be tested. Well, we run the automated and we say the same thing. Now we either have to send it out, or if you have somebody skilled enough and you've got a microscope, you can look under the scope yourself and see that there's, either no blood cells or there is. So it's kind of, to me, very useful knowledge to have.
So on the urinalysis, on a dip urinalysis, the automated one, when microhematuria is read out, it could be trace. When it comes back trace, you may not want to put too much stock on that trace, or you can have moderate, or you can have large. So when it goes to moderate or large, you're pretty certain that there's red blood cell in that specimen.
Yeah. We do have some questions coming in here. So how does a lab tech determine what part of a slide to count the cells to determine, say, 100,000 E. coli per high field? If the slide has many cells, does the tech focus on the most dense portion of the sample? I don't know that I have a 100% answer to that, but there are counting microscopes that have little graphs built into them that you can count the number per square, and that's multiplied. I can tell you from looking at samples that you don't really tend to have like one spot on the slide that has a lot and another part that doesn't. So I just look at different areas and kind of pick an area to get a generalized count.
Certainly, there's some subjectivity.
Yeah. Oh, absolutely. It's not an automated. Another thing that probably AI will take over, right? We'll just slap the slide in. The AI will be able to glance at them all and give you an exact count.
Yeah, there's no reason for that not to be automated.
Yep. Janelle Finn, does Urabel give a false positive for nitrites? Again, the color can interfere. I don't know that it's going to necessarily give a false positive. Urabel, I think, is that the one that makes it green?
Green or blue, I can't remember.
Yeah, I
I
think
haven't
so.
used that in a while.
Yeah. So, but
Because-
again, it could interfere with it. Any of those will interfere with the colors that you see.
Yeah.
Susie Swain, is there something, if you see something show up under microscope, would you send urine to the lab for further testing? I'll put this one to you, John. What would you do?
Well, it depends. What are you looking at?
Yeah.
You know, what is showing up mean? What are you looking at?
Right. If it's a semen sample and you're looking at a post vasectomy, you know, which I don't think too many people do anymore because most of these labs are a lot easier. Patients prefer just to mail them off. But I guess if you did, would you need to send that off? Well, one, you know, if you see 1 or 2 under high power, you're going to recheck it anyway. So.
Yeah, it just depends on what you mean by something showing up under the microscope.
Maybe if you want to clarify that in your question.
So if you're seeing a young lady with the prototypical urinary tract infection symptoms, and then you look at the UA under the microscope and you see bacteria, yes, you would probably send it for culture and sensitivity, and then you would treat the lady that same day, empirically. And then I always tell the patients, I reserve the right to change your antibiotic depending on what the urine culture and sensitivity show.
Monica Friedman, we don't use the microscope in our clinic, unfortunately. What indicates UA microscopy reflex to culture for urine specimen versus UAR-UC, no microscope? So I think your question is, when do you send it off for culture? I think we just answered that one. With if I understand it. So you get a patient comes in with urinary tract symptoms and you see bacteria, and you under the scope, then you would send it off for culture. Hopefully that answers your question, Monica. Susie Swain said, awesome, thank you.
I don't know, Monica may be asking if you have an automated UA, when or what does it mean when you reflex send it for culture?
Yeah, I'm not understanding the question myself too well. Monica, if you
Well,
want,
maybe if there's nitrite present in the urine, or maybe leukocytesterase.
Yeah,
I don't automatically. I don't auto reflex anything. I'm very cost conscious, even though it's not coming out of my pocket. Somebody's paying for it, so I look at the urine. I look at the patient, and then before I send it for a urine, like a fish test for urine cytology or anything like that. I don't reflex any genomic test or genetic test for prostate cancer. I look at the patient, I talk to the patient, and make sure that it's okay with him before I send it for any genetic test for prostate cancer.
Yeah. Unfortunately, there's a lot of tests out there now. Everything's being tested for everything. And I think there's probably some oversensitivity to some of these tests, these urine cultures that are going out that are based on DNA, are picking up infections that are not necessarily found. And maybe that's good on somebody who's coming in with recurrent infection. They're being treated. They're not getting better. Now you've got something that can say, hey, wait a second, maybe it's because we've got this other thing that we're missing. But as you said, to put everybody through that just doesn't make sense.
Yeah. Unfortunately, unfortunately, there was a large profit motive for PCR testing, especially if you're doing it in the office to bring it in-house. So several years ago, there was a large increase in the number of PCR testing. The payers got smart, including Medicare. So now the payments have been decreased. Some practices that have been unscrupulous in using this indiscriminately are getting their monies taken back, clawbacks. So no matter what you do things correctly, have a protocol, follow the protocol, make sure that it makes medical sense, medical necessity, and makes scientific sense.
Okay, so Monica did come back with actually wondering indications for microscopy versus no microscopy in UA. So when would you just not do strictly do the automated? I think you do the automated on everybody.
Yeah, you can automate it super easy, right? Not everybody. I mean, it's a healthy guy coming in for vasectomy. I'm not doing
Right.
UA on him. So yes, a lot of people say we do a UA on everybody, and then you get to charge $2 for every patient. That is not the right way to run a urology practice. Pretty soon, if you do that, insurance companies and the payers are going to bundle that with the E&M service, evaluation and management service. So you don't want to do that. You want to be discriminate in appropriately using urinalysis. Even though the patient's coming in to a urology office, it does not mean that you do a urinalysis. That's like saying every male coming into the urology office, you do a rectal examination because he has a prostate. No, you don't do that. Same thing as urinalysis. You do not run a UA on everybody. So as to if there's an indication for urinalysis, you can certainly run a microscopic if the equipment and the expertise are available, or very simply an automated urinalysis. And Vic, you mentioned last week, if you buy a certain quantity of test strips, often that automated machine is thrown in as an incentive for you to buy the test strips.
Yep.
And you also mentioned, or somebody mentioned last week on urinalysis, if you're having your staff manually entering every single piece of information in your EHR to capture, or if you're printing out that little slip and then scanning it into the EHR, anytime you have to print something and scan it back into something, that's an inefficient use of your time and resources. Consider finding a way to automate and integrate that so that the machine, and there are ways to integrate that, that machine will read out the answer, the report, and then you automatically drop that into the patient's chart in the EHR for today's visit. So some hot tips there.
Absolutely. We have a couple more questions coming in. Gene was asking, can you explain PCR?
PCR stands for polymerase chain reaction, basically looking at the more of a DNA aspect, if you will, put it simplistically. A DNA signature of certain types of bacteria that may not be detected or tested on routine urine culture. So if you have someone who constantly has the UTI symptoms, you run the routine urine culture and sensitivity, comes back and showing no growth, and the patient's still symptomatic, that may be an indication for a PCR or more detailed test where they'll test a ton of different rarer bacteria in the sample, and then you can then treat that patient with the appropriate antibiotic.
Yeah, and it's just boils down to it's a technique for amplifying the DNA in the sample that they're sent. That's what the PCR chain does. Very good. I got a thank you from Monica. All right. I think we're getting close to the end of our show. I don't see any other questions coming in. I think that this was a great, hopefully this was a great topic for everybody, because I think there's a lot of these little things that we do every day. And again, my goal has always been to try to share the knowledge, the tips that I've learned over the years of doing this stuff and finding better ways to do things. So, and you guys out there can share too, because it's always somebody has a better idea.
And Jean, Monica, and Susie, and gosh, there's another person, Janelle, Elizabeth. If you are watching this, and obviously, most likely you work in an office of staff that also deals with urology, I encourage you to tell them about Urinurse so they can watch us live every Saturday and ask questions like what you're doing, because this is a very safe time, very safe space for people to ask kind of semi-anonymously about things that may be in the back of your mind that you want to ask. And maybe you're too embarrassed or too afraid to ask. This is a great forum. So please share that this Urinurse platform. And I think the Saturday after Thanksgiving, Vic, we're doing an Ask Me Anything episode. So that would be a good time for you to bring any questions that you have.
Yeah. And that's kind of when I founded Urinurse, and I was coming up with ideas of how I wanted to do this. And I could have done it as simply like an interview, like almost like John and I are today, kind of talking back and forth. But I thought, no, really what I wanted was a way for you, the audience out there, to be able to interact with all of us, you know, the experts, people that have been doing this for a long time, and bringing in experts from all sorts of areas. And it's it's been blowing my mind at how well it's worked, how much people like it, how much feedback I've gotten that's positive. So I'm really thankful for having the experts, and I think this is a great format, and I continue to want to push it forward. So with that, let's talk about next week.
At uronurse.com, we are privileged to have a team of expert presenters who are well versed in the field of urology. Their wealth of knowledge and experience makes them valuable resources for anyone seeking information on urological issues. Feel free to ask them anything you want to know about urology. From general topics like common urological conditions and their treatments to more specialized areas such as urologic surgery techniques. The experts at uronurse.com are committed to sharing their expertise and fostering a better understanding of urology. Join us at uronurse.com and ask us anything.
So yes, that's what's going to be on for next week. Join us, and we hope to have a large live audience for questions. But you can also go to the website, uronurse.com, and there's our contact us button. You can submit yours. If you're not going to be able to make the show, go ahead and submit your questions, because your questions are going to be what's driving next week's show. So either we won't have a show or we will have a really great show. But if you come live, I am going to be raffling off a Uronurse t-shirt. It's a little incentive to come live. The only way you can win the shirt is you have to be live. Now, you can be live on Facebook, YouTube, or StreamYard, or LinkedIn. Any of those will work. But you got to be here as a live audience, and you'll be able to put in your name and a special code that I tell you, and I'll be raffling that t-shirt off. So join us live. I hope it's going to be a really great episode. I can't wait to just sit and chat with the experts and ask anything you want to know. So, John, thanks for all your help today. Really enjoyed the show. And with that, we're going to go ahead and call it a show, and everybody go out and enjoy your day.